speech of the patient, but this is especially relevant in cases of psychiatry. So if the patient is feeling anxious, you have to acknowledge it. If the patient is feeling upset, and this is very important, that you do not make a comment like, if the patient is feeling scared and you make the comment that the patient is feeling embarrassed. So make sure that you use the right word which matches with the behavior of the patient. And then appearance and language of speech: patient is loud, patient is fast, or I can see there is a message. uh, do we tell about the speech and appearance? No, of course we do not tell about the speech and appearance, but this is for you to notice. And in cases where after 6 minutes, for example, in some it used to be previously, I don't know if such cases have come recently. If you are supposed to discuss the case with the examiner at the end of 6 minute bell, then you can make use of this information. Otherwise, this information is useful just for your own self, that when you're that it just, it's going to give you a hint towards the diagnosis. That's all that it can do. But behavior, yes, you can make a comment on the behavior. You can tell the patient that I can see that you're feeling like that, and what might be the reason. Yes, of course, while talking to the examiner we can use medical language, of course. uh, Then there's another mnemonic that we should learn, because as I told you earlier, that in this session we're going to try to go through different key information that is going to be helpful while taking information, while taking history of a patient with psychiatric illness. And there are not a lot of psychiatric scenarios. So in the next session, we'll try to cover the scenarios, and one by one, and make use of all this information that we're learning. So recreational drugs, again, it might be that the scenario might be even about alcohol or about some recreational drug, or it may be that the scenario is about some other psychiatric illness, but the patient has comorbid substance use disorder. And so you have to you might need to ask about you might need to explore this habit in detail. So remember, this is also principle of PLAB 2, and not only relevant to psychiatry but in all other specialties as well. But whenever some positive finding comes, do not ignore it. Like you're taking a history and you ask about something and the patient says yes, it is like that. You're asking, the rest is no, 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 and something is yes, something comes up, yes. Do you smoke? Yes, I do smoke. Or you do not just go on, because if you go on, it's harmful for you in two ways. First of all, it just doesn't really give a good impression to the examiner that you came across a positive finding but you did not explore it. And secondly, not exploring that positive finding can be detrimental in the way that you might miss important stuff that you do need regarding diagnosis and management. So whenever a positive finding comes, you have to explore it. And this is so in psychiatry station. If you're asking about famish, and when you reach a part of the famish, alcohol or other drugs, you ask to use any recreational drugs, and the patient says yes, then you have to explore this habit. And how do you explore it? This is a mnemonic. I'm sure you must, or all of you must be familiar with the mnemonic CAGE and TWD. C stands for cut down. Have you ever tried to cut down your drinking? Have you ever tried to cut down the use of heroin? A is for anger. You get angry when someone talks to you about your drinking habits, and someone talks to you about about the use of this substance. D is for guilty. Have you ever felt guilty regarding its use, or have you ever felt guilty due to some of the maybe some of the um activities that you were involved in when you were acutely intoxicated with that substance? Have you ever used it as an eye opener in the morning, first thing in the morning? Tolerance, have you felt that you gradually need to increase the dosage to reach the same effect? W for withdrawal. Do you feel when you do not get that substance, or when you do not drink, do you feel any physical or psychological symptoms? Do you feel anything that forces you to drink again. D is for dependency. Do you feel that you cannot properly, you cannot work, you cannot maintain that you cannot perform your daily activities without this substance, you're dependent on it. So you have you this is of course to assess whether the use of that substance is just a use, or it's patient is or misusing substance in a harmful way, or it has reached to the level of abuse and the patient is outright addicted to the substance. So again, some of the questions may be positive, some of the questions may be negative, and on the basis of how many plus you get, you can ascertain that this much severe this problem is. This is how severe the problem is. Again, it can be mild, it can be moderate, it can be severe. And also remember, uh, if it's like in case of alcohol, it's obvious that we drink it, but if there is any other recreational drug comes up, you should ask about the root of the drug. You should ask also, and in addition to these questions, even regarding alcohol, you should ask about the amount that the patient uses and the route that the patient uses. And then let's, very important slide next, we have attempted suicide. As I mentioned, there is a scenario, a very important scenario that keeps coming in PLAB 2. That is that a patient has come with paracetamol overdose, and medical team has assessed the patient, and they have said that the patient is stable. They have ruled out any possibility of liver damage, and they have called you. You are a psychiatry senior house officer, and your task is to make sure whether the patient is safe to be discharged, or whether the patient needs further input from the psychiatric team and needs to stay in the hospital. So, and not only about this scenario, again, this whenever self harm comes up, whether it's this scenario in which the primary complaint is self harm, or if there is any other scenario, like in cases of depression or in cases of psychosis, when you ask, have you ever tried to harm yourself, or sometimes people with these kind of struggles, like you've been having, they sometimes think of harming themselves. Have you ever had such thoughts? And if you ever come across a positive finding of self harm in any scenario, you need to explore that self harm, and for exploration of that self harm, this checklist can be used. And again, the first off, planning. If the patient has planned that attempt, if the patient has been planning it for quite a while, or if the attempt was thoughtful, then it is more likely that he will repeat it in future. So if it is positive, then of course it will incline you towards admitting the patient. Second, intent of self harm. Again, sometimes again the self harm can be, as I mentioned, it can be impulsive, and it might not be thoughtful. It can be impulsive after some acute event, or sometimes it can be, it is on the background of long standing mental health illness which involves suicidal ideation. So on the basis of why the patient harmed himself or herself, and how long has he or she been planning for that, that would determine the decision regarding admission. Previous attempts, if there are previous attempts, then it would increase the likelihood of further attempts in the future. Access to weapons, means of self harm. If you are going to discharge the patient, you're going to have to make sure that the way the patient lives, there is no free access to resources which can be used for suicide or self harm in the future. If there is no social support, well, it's a risk factor. If there is social support, it is a protective factor against future self-harm attempt or future attempt of suicide. Domestic violence, or history of domestic violence or sexual abuse, again increases the propensity, increases the possibility of attempted suicide in future. And no insight, if the patient does not regret it, willing to do it again, and does not see a future, then again that is a poor prognostic factor. And so if If these factors are positive, that means that you have to go for admission. If these factors are negative, then that means that you can safely discharge the patient with outpatient follow-up. So yeah, there's a okay. So next slide. If you have any questions so far, you can ask. So next slide, examination and relevant bedside investigation. In cases of psychiatry, the examination would include just general physical examination. If there is a complaint, a physical complaint, like there can be in cases of somatic symptom disorder, but I don't think there is any in case of the psychiatric stations that we see here in PLAB 2. So general physical examination in case of anorexia or bulimia, you should also perform systemic examination and relevant bedside investigations. In all cases of psychiatric like if there's a depression or psychosis or uh, dementia or delirium, you should always perform baseline investigations like CBC, LFTs, RFTs, serum electrolytes, ECG. So these need to be performed, and thyroid function test. Thyroid function tests need to be performed because uh, mental health disorders can present secondary to thyroid hypothyroidism or hyperthyroidism. And the other investigation that would depend upon the specific scenario. For example, in case of dementia, during examination we'll also perform a mini mental state examination. There are two scenarios of dementia in PLAB 2. One is in which the primary purpose of the scenario is to see whether the candidate can perform mini mental state examination adequately, and then at the end of 6 minutes you're supposed to discuss with the examiner. But I think it's probably been a long time since that scenario came. The second scenario, which has been coming more frequently, is when you do not need to perform any mental state examination. You just need to mention it that I would like to perform any mental state examination, and you will be given the findings. So, and then the bedside investigation, like in case of, let's say, in case of dementia, will be performing vitamin levels, will be performing thyroid function tests, will be performing rest of the baseline as well: CBC, LFTs, RFTs, serum electrolytes, serum calcium, um, uh, and vitamin B12 levels, folic acid levels, and uh, if history suggests or examination suggests that any other any other investigation needs to be performed, then that as well. In cases of delirium, for example, we have to perform chest X-ray, urine complete examination, ECG, and if the patient has also if the patient has fever, then we need to perform blood culture as well. So because we are we're going to have to explore what is the cause of delirium. So I think other than and in depression, as I mentioned, only the baselines. In psychosis, the baselines. Anxiety disorder, the baselines. Uh, then moving on to explaining the diagnosis, it can also be very tricky. And like I mentioned, in all stations of PLAB 2, we need to be sensitive. But in psychiatry, we need to be extra careful and more sensitive to the patient's emotions. Uh, Most of the times we're going to have to explain it to the patient, and occasionally, like in cases of psychosis, we might have to explain the diagnosis to the relatives. And it's not going to be any different. We're just going to narrate again the positive findings in the history and examination, and we're going to narrate that on the basis of these findings. I'm suspecting that you might be going through what we call depression, or you might be going through what we call this and that. And then comes management. In all of the in the psychiatry stations, the most important part of the management is this, is just to because of course we are at FY2, senior house officer level, so they don't really expect us from us the details of all the uh, management options for different illnesses. We just need to screen the patient, whether the patient needs admission in inpatient or whether the patient can be discharged on outpatient. We need to screen whether the patient needs to be admitted or not. So that is going to be the recurring theme in cases of psychiatry stations, and also again in other PLAB2 stations as well. This is a very important part of the management, and we cannot make any mistake in this part. We need to make sure that we formulate that regarding our management plan. We're confident whether the patient needs admission. If the patient needs admission, we cannot start him, because you know that the PLAB2, what PLAB2 needs is, or what what they are assessing in PLAB2, or what they want from us is they want a safe doctor, a safe doctor with good interpersonal skills. That's all they want. So interpersonal skills are really important. And regarding your clinical decision making, you just need to make sure that you're safe. So of course, if you discharge a patient who needs admission, and that can be really harmful. So the rest of the treatment, of course, in every case would depend upon the severity. And on the basis of the severity, for example, in depressive and anxiety disorders, if the severity is mild to moderate, you can refer the patient for CBT or talking therapy. In cases of moderate to severe, you can refer the patient for pharmacotherapy to a psychiatrist. In cases of psychosis, you have to admit the patient, all right, because the first episode of psychosis is an indication for admission. As we mentioned, as we saw in FAMISH, I stands for insight. If the patient does not have insight, then of course we need to admit the patient to enforce the treatment under the Mental Health Act. And some of the really resistant diseases can go down to ECT and that, but of course we're not going to discuss that. Just support groups, talking therapy, and sleeping pill. It's really important. Like whenever one scenario would come, and it can come, and it can also uh, be in the scenario of depression. When you're talking to the patient about antidepressant therapy, then the patient might be really reluctant to take antidepressants, and he might have this concern that antidepressants are addictive. So you have to make sure that you have to reassure the patient that no, antidepressants are not addictive, and you can taper them down after a certain amount of time. So this is important regarding antidepressants. Make sure that when you go through the scenario of depression, you explore all the concerns that a patient might have regarding antidepressants, and you address them one by one. And finally, safety netting would include safety netting for suicidal ideation or worsening of the symptoms. So I think we're running out of time anyway. So this was a brief discussion of the main points, of the key points that one should remember while going through a psychiatric station, a psychiatric scenario. And in the next session, we'll be going through the scenarios in detail, one by one. So if you have any question, you can leave in the chat box. If the meeting ends, you can leave this question in the comment section on the YouTube channel, and I'll try to answer it. Right.